Welcome everyone to the 3-month progress report where I'd like to talk about my PhD, which is titled Targeted Neuroprotection for Post-Cardiac Arrest Patients. My name is Krisztina Csőke-Kabai. I work at the emergency department of the University of Szeged. I'm also a first-year PhD student. My vision is that all resuscitated patients should thrive and not just survive, and my mission is to drive therapeutic innovations for better quality of life following resuscitation. To reach my goals, this year we've launched 2 projects. Both of them are about the neuroprotection of resuscitated patients. One of them started in September and the other one in November. Let me start with my first project, which is investigating the efficacy and safety of pre-hospital targeted temperature management on neurological outcome in out-of-hospital cardiac arrest patients. So the problem is that out-of-hospital cardiac arrest happens to 1 in every 1,000 people just alone in the United States. 50% of these patients receive resuscitation. 30% of them are successful, but the neurological recovery stays very poor, around 6%. We know that the hypoxic ischemic brain injury is responsible for this very poor neurological outcome. It leads to increased mortality and prolonged disability. The cerebral metabolic rate for oxygen is reduced by about 6% for each 1 Celsius degree reduction in the patient's core temperature. So the whole process of cooling down the patients to 33 degrees aims to prevent secondary brain damage. Literature suggests that a delay in reaching this target temperature may even worsen the neurology in in-hospital settings, and they recommend it to start it as soon as possible. So we would like to answer the question that is starting targeted temperature management pre-hospitally might be neuroprotective for patients. In order to find this out, we can investigate the impact of pre-hospital targeted temperature management on neurological outcome. Our clinical question is, does starting targeted temperature management pre-hospitally improve neurological outcome and reduce post-resuscitation complications in out-of-hospital cardiac arrest patients? Our population will be patients after out-of-hospital cardiac arrest. We would like to compare target temperature management started pre-hospitally to the procedure started only in hospital. Our primary outcome will be neurological functions, and our secondary outcome will be survival to discharge, 90-day mortality, recurrent arrest, body temperature on hospital admission, time to reach target temperature, and adverse events. Our hypothesis is that pre-hospital targeted temperature management improves overall neurological outcome. The clinical implication is that pre-hospital targeted temperature management becomes the standard of care, and then fewer patients will need round-the-clock care, which will lead to personal, financial, and economical benefits. Our primary outcome is measured as favorable neurological outcome, defined by the patient being able to live an independent life. This is reported a couple ways in the literature. First one is the Cerebral Performance Category Scale, which ranks from 1 to 5, 1 meaning no or minor disabilities, to 5 meaning brain death. And another scale similar to this is the modified ranking scale, ranking from 0 to 6. And on the slides you can see the categories of patients who have good neurological outcome. According to literature, these categories correlate with each other. You can see our systematic search key. The last search we did was run on the 3rd of November when we submitted our Prospero registration. Consists of 3 domains. The first one refers to the intervention, the second one to the patients, and the third one into the study type, which is only RCTs in our case. The searches were conducted in 3 databases, and you can see the number of hits that we received in each database. After the duplicate removal, we had 4,962 articles to go through with my selection pair and with our project student. And with a Cohen's kappa of 0.81, we identified 113 articles to go through the full text selection, which is currently ongoing right now. We have some preliminary outcomes, which I'd like to present. You can see that the first set of the articles represent the short-term, and the second one, the long-term good neurological function of patients. If you compare the event rates of the 2 groups, the ones who received and didn't receive pre-hospital targeted temperature management, you can see that the number is pretty similar. So so far, right now, this suggests that there is no clinical difference between starting the procedure earlier or later. Let me move into my second project, which is investigating the efficacy and safety of seizure prevention on neurological outcome in cardiac arrest patients. The problem is that after cardiac arrest, a large variety of possibly pathologic EEG patterns can evolve in patients. These are called the rhythmic and periodic patterns, or RPPs. These are present in 1/3 of patients after cardiac arrest, and they can even go unnoticed, especially if you don't use an EEG. We know that the cortical synaptic activity is very sensitive to hypoxemia and ischemia, and this leads to a post-anoxic status myoclonus. These seizures may even appear days after the cardiac arrest, and while 1 or 2 incidents might not be an indicator of neurological outcome, but if they're repeated or if they go on for as long as 30 minutes, the fatality rate can be increased up to 100%. So we'd like to know that if we prevent these seizures even from happening, can that be neuroprotective for the patients? And in order to answer this, we can investigate the impact of seizure prevention on cardiac arrest patients. Our clinical question is, does seizure prevention improve neurological outcome and reduce post-resuscitation complications in cardiac arrest patients? Our populations will be patients after cardiac arrest without seizure. Our intervention is seizure prevention therapy. The comparator is standard care. Our primary outcome is neurological functions, and the secondary outcome is survival to discharge, 90-day mortality, incidence of seizures, and adverse events. Our hypothesis is that seizure prevention improves overall neurological outcome. Our clinical implication is very similar to the one in the first project, with better neurological outcome, fewer patients will need round-the-clock care, and the quality of life improves. So to summarize this, the first project should be finalized in September next year, and the second project should be submitted in the spring of 2026. I would like to close my presentation with an English idiom: where there's a will, there's a way. Thank you very much for your attention.
I just have one question. What tools do we have to perform targeted temperature management pre-hospitally?
It's a good question, thank you. There are actually multiple ways that can be used even pre-hospitally, and they are used throughout all of the articles that we wish to include. One of them is giving cold 4 degrees IV saline to the patients. And other ways include devices like nasopharyngeal devices that are applied into the nose, and they cool down the oxygen as they are given to the patient, because the patient would be given oxygen anyway, and the oxygen is cooled down like that, and then the patient's head is cooled down very rapidly. Another way is to use cold blankets or ice packs, or I just read about cooling caps too that we can put on the patient's heads. So there are multiple ways.
My question would be that what was the resuscitation or door to hospital time in these studies? Because one of the reasons why there is not a tremendous result is that, for example, in Hungary is less than 15 minutes. If you calculate it, how much you can cool the patient down within 15 minutes, you cannot cool it down perfectly.
Yes, it's a good point.
In the USA, it's totally different. Of course, it can be even a 1 hour time. That's so. It's important where you get the patient data from, which country.
It's a very good point, and you're absolutely right, because the articles that I have read so far in the preliminary phase, they're either from Europe or from Australia, because Australians like really this topic, because in Australia it's warm and the transport time is very long. So they have like 20-30-minute helicopter rides when they get to a center with an ICU. And so they are investigating it. And when we pull these results together, we can actually make even subgroups based on the ambulance time. But I think it's very interesting to investigate it, because in the hospital settings they say to start it as soon as possible, but because their results are better if they start it as soon as possible. But so far it doesn't seem to reflect it in the pre-hospital phase. So I think this is a contradiction that should be studied further.
Back to the first question. Did you by chance check if the northern countries, the resuscitation in the northern countries, the outcome is better than in the Mediterranean? Because most patients do get the outside temperature, accommodate themselves to that. So maybe there is already a cue.
Yes. Besides the European studies mostly include northern studies, yes, from Norway and Sweden. They also like to investigate this topic. And I think that when you pull these results together, based on these mentioned differences, they kind of like balance each other out, because the differences are there. Maybe they're not significant, but they are better. But then you compare it to other countries when they have not better results. So if we pull them together, it's just like balanced.
What can be the significant time differences between the pre-hospital treatment or in-hospital? So it's minute, or how can we count?
Yes,
minutes,
it's measured in minutes, absolutely measured in minutes, especially in countries when the ambulance arrives in minutes and gets to the hospital in minutes. One other outcome that we investigate is the body temperature of the patients when they're admitted into the ER. And so far, it looks like that the people who received this intervention pre-hospitally, they have a significantly lower body temperature on admission to the hospital, so they need less time to reach the target temperature inside of the hospital. They need like 2 hours, while the other people who are, when the intervention started in hospital, they need like the more time, like 3 hours. So it significantly reduces the time to reach the target temperature, and that could be one good cause to start it earlier.